Our power group is the Shelby County United Way Women's Initiative Group. So it stands for Passionate, Optimistic Women Encouraging Results. So that's the acronym for POWER. And it was organized in 2013 with just a handful of charter members. And today, I am happy to report we have 106 members. And the mission is to build a powerful force of women philanthropists, and we unite in service in many different ways, and financial resources as well. And to join POWER, it's only $50 a year, and that's a membership dues, and basically that helps towards our mission to help children in Shelby County. So far, we've been able to allocate over $50,000 back into the community through our powerful grants. And this year, we're happy to say that we are able to allocate $21,500 to 18 different organizations. And we also have what is called the Empowered program, which is a kindergarten tutoring program, where we recruit professionals in the community, as well as some of our POWER members and retirees in the community, to do kindergarten tutoring. In this past 2 years, we've been able to put kindergarten tutors in all 10 kindergarten classrooms in Sydney, Monday through Friday for an hour. So unfortunately, with the COVID situation we have going on, we're not going to be able to do that this year. We're hoping maybe in the latter part of the year or the last 9 weeks of school, we'll be able to do that. But so what POWER does is we schedule those tutors, and then we also pay for the background checks as well. So that is one of our big initiatives as well. We also do some volunteer work in the community as well. And then we also have a number of programs throughout the year that the POWER members can come to, like this one that we usually have in person. And usually these programs educate them on something personal or financial or community topics. So that is kind of what POWER does, and it was established, like I said, back in 2013 through the United Way Enhanced Giving Committee, and has expanded greatly, and we're always looking for new members. We have a website, powerforwomen.org. You can go on there and check out all the great things that they do. You can also join on there as well. And we do have some brochures too that we can pass out or give to people that they can fill out and join that way as well. So that is what POWER is and what we do. And today, of course, we are virtually connected with Dr. French at Wilson Health, who's the interventional cardiology there. And we're excited to see what he has to share with us today.
Well, thank you, Amy. Yeah, we'll keep it, casual. I guess you're going to run my slides for me, but yeah, I am an interventional cardiologist, and that's kind of, you go through training with internal medicine and then cardiology, and then do a year of like balloon and stents and different things, but you never really get away from being a general physician, taking care of people, both men and women. So can you do the first slide, or
yeah,
can you pull that up, or do you like yeah, there you go. Okay. So, as we've all become, familiar with PowerPoint over the years, it is a very timely topic, honestly. Medicine, like many things, has really kind of done a disservice in terms of, my love is heart and vascular. It always has been. And, for 25 years, but, many studies for many years didn't include women in studies. And so, you've seen a lot of academic centers realize that cardiovascular disease in women is an almost entirely different subject, different beast. And I would say the last 10 years, there's been an incredible push at major academic centers to have women's heart health almost as a separate specialty rather than cardiology. Next slide, please. This is Amy and I kind of coordinating this on the go.
Are you guys seeing the slides okay?
Yeah, that's perfect.
Okay. I'm trying to get the next slide here. And they're seeing the slide, but it's not.
Like maybe I'm gonna let maybe an enter or a click or a.
Yeah, hold on 1 second.
Yeah, take your time. But anyway, so while she's figuring that out, I mean, the slides aren't really as important as, understanding that if I were to if I were to ask you a question, if you thought what the #1 killer of womankind is, a lot of people would say breast cancer. And breast cancer is actually, about 6 times less likely to kill you than cardiovascular disease. And do you want me to, Scott, you're on it?
I'm working on it. See what happened. We just had it up.
Okay, I see it. And you've got everything.
What are you seeing now?
I see it, but I mean,
Do you see the second slide?
No, still the first slide.
Yeah. So let me ask you, can you if you scroll your mouse down, like the ball on it, will it go?
It's actually within Zoom right now on the. Okay. We're gonna pull it up fresh. That's it.
Yeah.
I've got a back, if that doesn't work, we can go, I mean, I can sort of go off. I'm sure you'll get it, but.
There we go.
Yeah, maybe you can just click on them and,
How about now?
Yeah, that's okay by me.
I see it.
Yeah, it's good enough.
Did it
There
just
we go.
So this is a kind of a boring slide, everyone puts in there, but I mean, we've heard a lot about epidemiology in the last 6 months, and it's kind of an imperfect science. It's sort of a way of looking and trying to figure out, if I wanted to go into something, I really might try to go into this these days, because it's a lot of statistics, it's a lot of population health, it's a lot of trying to predict where needs are going to be, and it's very hard, as you've probably figured out with models. But understanding a mechanism of a disease and how it differs in different populations, I mean, that's kind of what we do as in training. And just talk a little bit about that. Then I'll just talk a little bit about screening, what women can do, and then a little bit about prevention, and then a little bit about some of the testing that's out there, some of the Dr. Oz stuff you may or may not see that you're kind of like, should I believe this or not? Or next slide, please. So like when I go like give a talk or something, I only like really like want to have 5 takeaway points. I never want to go any higher than that because I know that no one ever does. I think the most important point is that heart disease is the most common killer of women in the United States. You know, if you go on the street and ask people, they will say breast cancer because, you know, it has such a, there's so much money in it. There's so much, the Susan B. Komen Foundation, you know, it has a lot to do with, you know, survivability. My sister had breast cancer, survived it. You know, a lot of women, unfortunately, you know, it is kind of a silent, it's kind of a silent group because a lot of these women do die. You know, if when they do have a heart attack, it's a little bit of an older population, so there's not as large of a you know, of a push to educate until recently, and we'll talk just a little bit about that. But you know, so the first point is really that it is the #1 cause of death. If you want to know where your risk factors are, it is the #1 cause of death. You know, it might be morbid, but it is also the #1 cause of death. We know that in men, but it is also the #1 cause of death in women. And so why don't we go to next slide. So the one thing we kind of, you know, this slide's a little blurry, a little busy. We, you know, we tend to kind of, you know, switch things off the Google machine a little bit, but in this day and age. But actually, women's signs are mostly like men. I mean, I'm the guy that, you know, gets called in the middle of the night when someone's like finally negotiates and it's not heartburn and they think they're having a heart attack, and we come in and see them, and really the symptoms are the same, except, you know, sometimes women will, you know, have a little bit more nausea, a little bit, maybe some more fatigue. This isn't just like when someone comes in for a heart attack. It may be just that they've got a significant blockage and they're so young and healthy looking that, you know, a lot of cardiologists end up missing 1 or 2 of these and saying there's just no way that, and, you know, there is a way, and it does happen. And then I think the previous slide that showed you the statistics, you know, need you to be aware of it. But most of the time, you know, what we're talking about is when you know, people walk or they're mowing the yard or they're exercising, doing a walking program with their partner, and they get a little tightness or heaviness, and it's relieved with rest in about 5 minutes. It's not something that's sharp. It's not something that lasts all day long. It is usually brought on by rest or by exercise and relieved with rest. And that is like, you know, not a heart attack, but when you start to get a significant blockage. A heart attack in both men and women, honestly, I've never looked in someone's eyes when they're actually having a heart attack. And, you know, after seeing thousands of them over 25 years, they know something's wrong. I mean, they can tell, like they know something's wrong. I mean, every now and then you get it. It never happens with a woman, but you will get a guy that thinks it's just heartburn, and he goes through the, you know, Labor Day or July 4th weekend and doesn't come in till later. But generally speaking, sweating, a feeling of something's definitely wrong, you know, tightness, pain, that is the one. 911. That's where, you know, you don't take chances on that. And, you know, you've all seen the commercial where there's no one that wakes up and says, today's my day. I'm going to have one. I'm ready for it. I've been preparing for it. You know, it honestly, there's a period of negotiation. It happens that day. And to almost 100%, the patient says, I felt fine yesterday. I don't know what, you know, like, and it is a surprise event. And so, you know, I think that's kind of a second point I would put in there with, you know, understanding that it is the #1 killer of womankind. The symptoms are a little different, but not a lot different, and no one expects it on that day. So, you know, it is the kind of thing, we see it all the time. Next slide. We don't want people driving themselves to the ER. We don't want people, you know, making an appointment for Monday. It's a true emergency. So here's the real thing, okay, about it. The reason I said that breast cancer has a huge organization and a lot of money behind it is because people survive, and there are survivors, and you know but 64% of people, unfortunately, you know, you'll read in the obituaries, they die in their sleep, they don't make it to the hospital, and we don't see them. And so in general, again, not being morbid, I would say women have generally about 10 years of protection. It happens 10 years earlier in men, but when it starts to happen in women, let's say it starts to happen in men in their 50s, if it starts to happen in women in their 60s, if 64% of women die with sudden cardiac death, which basically means an arrhythmia, the heart stops, ventricular fibrillation, that population doesn't have a voice. So, you know, that's where the problem is here. Too, in terms of, you know, getting the message out. Next slide. And these are the common things, you know, that we talked about. I mean, I've seen chest pain anywhere up to the nose, never below the waist, ever. I've seen it in the jaw. I've seen, you know, both arms squeezing. I've seen sweating. I've seen nausea, weakness. Trouble sleeping is very common, but that uneasiness that something's wrong. I mean, it's you know, if someone's coming to me, I have to start the process. Patients don't come in with a diagnosis across their forehead. You know, that's where we have to do our work. So next slide. So this is a slide. This is probably about 12 years old or something. I can't actually read it on mine, but people started realizing this. So it's talking about a rack at the top, but that women weren't protected from heart disease because of the protective effects of estrogen, that it was more complex. The studies were done mostly in men, and I'll talk a little bit about that in a minute. So next slide. So when I was coming out of fellowship, really around 2002, first time I kind of heard about American Heart Month and Go Red for Women. In February, I was at an ACC meeting, and Barbara Bush took it on as her platform, and started talking about heart disease in women. And then we made really February, next slide, American Heart Month. And this Go Red for Women campaign started with the American Heart Association. And, the usual thing is, we would see this come February. And I mean, it would be someone like Kristen. You would never expect this in a million years, or someone, and they'd come up and be like, yeah, I can't believe it. My cholesterol's normal. My blood pressure's normal. I, eat like, one piece of apple every 3 days. And, and all lo and behold, I had a heart attack. It doesn't happen like, like that, but that's kind of the stereotype that comes out to say, to try to raise awareness for this group that really doesn't have a voice. Next slide. So, we talk a little bit about screening and, as that we, we're a small but mighty host here. I just want to say again that it is really, I think of it myself, like, I'm a little overweight, and, I work hard, and we all work hard, and we neglect ourselves. Mothers neglect themselves. They take care of their children. They work. They are constantly taking care of other people. And, what's the first thing to go? It's going to be exercise and diet and sleep. And then, we get a little past 40 or 50, and then the body starts to show some signs. And so, it's that's our country a little bit, but those ones that present with sudden cardiac death, again, Mabel, or it's not Mabel anymore, it's Michelle and Susan. It used to be Ethel, Mabel, Opal, these older women that would have problems, but went out to cut wood, and lo and behold, they didn't come back. And I think most of us have some story in our family, be it men or women, where no one communicated that they were having and they were, oh, mom, grandma's always so stoic, she never says anything. All right, next slide. So this is a busy slide, and there will be a question. You'll have to answer each one of these. No, I'm just kidding. It's weird because I'm like, in medicine, we keep reversing ourselves on things. Like we say aspirin's good for everybody after 65, and then we say no, it's not. It's only good for people that have coronary artery disease or colon cancer risk. And then, we say, well, anything that prolongs the exposure of the ovaries and uterus and breast to estrogen is not good for cancer, but it is good for osteoporosis prevention, and it is good for heart attack prevention. Well, then in 2002, we kind of changed everything again with a major study that said, okay, if you're on, most people go on, like, what brings you? It's the hot flashes, the estrogen withdrawal, people feel terrible when they're going through menopause. And so, those symptoms bring, the woman to the doctor or the OB, and we start some estrogen, and we usually say, hey, if you've had a heart attack, don't start it. If you've had a stroke, don't start it. But if you've been on it for a long time and something like this happened, a heart attack or a stroke, stay on it. So that is the new guideline since 2002. And I wish we had a better, more clear message about that. But, that you try to take women's Premarin away, I will tell you, some of these, I've practiced in smaller towns, and I do not like the look I'm starting to get when we talk about that. So next slide, we're almost there. So what do we know? Like, we do know that, we try to want to intervene earlier. We know it's unfortunate. You guys are, an organization where, it involves mentorship. It involves bringing younger people up. people that are obese as kids almost have 100% chance of being obese as adults. So people that are, whose parents are diabetics from insulin resistance, it's gonna happen. What brings that out? We usually see it in the first pregnancy. The blood sugar is a little high, the blood pressure is a little high, maybe preterm delivery. We've always said, there's so much stress, smoking, it's kind of like one of those things. Well, it is hard, as it can be done, but it is hard to quit smoking. And so, vaping is, I used to say, I had patients that did get off of cigarettes with vaping. I did have patients that, but when they start advertising to youth, and we know that if they, you don't start drinking alcohol officially until you're 21. If you could just educate and delay the best you could until you're 21. The video games are a problem. The NFL plays 360, even though we're not going to have NFL this year. I used to like that. I'm like, get out and play for an hour, just an hour. Anyone can do an hour. So depression is a big one. If you're depressed, you don't feel like, from COVID, you don't feel like exercising. It's just, so it's, we're fighting all these things. All right, next slide. So, this is what I tell people, and I'm going to, just say this, in that smoking is like pouring gasoline on a fire to me. It's like, it honestly, anything can happen. I've seen a 29-year-old kid die of a heart attack that smoked with no other risk factors. It is like you just never know what's going to happen with that. It is to me, I would say, diabetes and smoking are neck and neck, but I would give smoking the edge in terms of being like the most powerful risk factor. Now, the good news is that, your risk really can return to normal, a third risk in 2 years, and it's equal to non-smokers in 10 to 14 years. Those are really positive things. So, there's lots of times someone you just keep suggesting it. You suggested it. I've had millions of people, not millions, but a lot of people. I sound like Trump here. I've had hundreds and hundreds of thousands of people. No, I've had a lot of patients that have come in, and they said, my doctor never told me to quit smoking. I'm like, really? That's not good. But, maybe it's the grandchild. Maybe it's that they have. Maybe it's the that they want to play with, or, if they do have the heart attack, obviously that's a major incentive. That people have a roadblock to their mortality. They start to understand their mortality, and we start to, we get that in our 40s and 50s, and we can get there. The next slide. So with regard to screening, these are just little things that I've learned in my time, and we've got 10 more slides. So this is a carotid ultrasound, and it's if you look at the picture on the left, this is a normal carotid ultrasound, and it basically, the carotid artery splits the common carotid, which you feel right here. It splits into the internal carotid, which is the big one, which goes up to your brain, and the smaller one goes to like the artery on your temple, your tongue, your thyroid. But you can see it's pretty clear, and it's a very easy window, no radiation, to see what your arteries look like. Now, if they look like this one on the right, then you're getting some buildup in there. And usually when the doctor listens to your, he doesn't say anything a lot of times, unfortunately, but he's listening for a bruit, which is just a sound of like turbulence, water over rocks, water over rocks. So to me, I do think a screening carotid ultrasound is good. Next slide. But the thing is, your insurance won't pay for it. But this is what you hear about. And to me, this is probably my third point behind that it's the #1 killer of womankind. You know, that no one expects to have a heart attack. This is a coronary calcium score, and this is the aorta. This shows a little bit of coronary calcium. This shows a lot of coronary calcium on the right. And, you know, it basically puts it on a bell-shaped curve, and we're going to say, hey, we're going to take Amy, and we're going to take everyone her age group, and we're going to see where, does she have a lot, does she have medium, or does she have none? And that's going to raise our, it's non-invasive, it takes 5 minutes, it's usually $49 to $99. There's usually a special in Women's Heart Health Month, which is February. And that's going to be like my major motivator to say, not to cath somebody, not to do a stress test. We don't do a stress test unless someone's having chest pain with exertion. But we can say, hey, let's go on that cholesterol medicine. You know, let's take that statin now. Let's get that exercise program going at the Y. Get your buddy to walk after work, or, you know, or at lunch. And, you know, let's just knock off 10% of your weight, and let's be aware that, you know, we're not immortal. I mean, everything's going to calcify. Your knees are going to calcify. Your back's going to calcify. We're not going to be Nadia Comaneci and be able to bend over and touch the, you know, but the coronary arteries, this is what, you know, an easy way to look and see where you are. Okay, next slide. So yeah, it helps me get people to stop smoking. Not surprisingly, obesity, same thing. You know, and I'm not going to spend a lot of time on this, but, you know, the next slide, this looks like a COVID map, right? I mean, Midwest, we're not doing too good. South, not doing too good. We're just overweight. I mean, it's, people are either salt food or sugar food. And I mean, I'm as guilty as anybody else. The average person gains 2 pounds a year if you do nothing at all. And everyone that sells food is not going to, you know, unless you're maybe Subway, I guess, you're not going to take into account the person's health. You're in it to, you know, say we've got bottomless, you know, pasta, bottomless breadsticks, come on back. And, you know, and so, you know, you really have to get creative, you know, split meals with your husband, different things. I always try to say, you know, Monday through Friday, let's make it a work week with meals, and then we'll take a break on the weekend. Or we'll say, you know, let's, you know, like I said, let's split meals. You know, it's cheaper. Let's cook at home. You know, you do it as a team and plan, because what is the worst thing that happens? It happens to me every time. I will start working hard. I get a heart attack that comes in, and another consult. Then I'm starving, and I go over to the whatever the Mexican place is that's really good over there, and I eat like 2 bags of chips and queso and a burrito, and then I'm like, I'm like, why did I do that to myself again? I didn't plan my meals. So, you know, plan your meals. All right, next slide. You only have to lose 10%. You don't have to be a fashion model. That whole junk about trying to live with, you know, an eating disorder or, you know, Vanity Fair or whatever the, you know, the magazine is of the day. It's only 10%. So, you know, you can improve your risk factors, and, you know, if you fall off, start again, you know, but get the scale, get the numbers, get the hard numbers. You know, I tell my patients, get up, go #1 in the morning, step on the scale, write it down. I mean, and and then whatever. Just keep yourself honest, whatever it is. Next. We all know this, okay? It doesn't matter. It does not matter. It used to be the Ornish diet in the 70s, 80s. This guy in California would be like, oh, vegetables will be, vegetables. And then it was the Atkins diet that, why do we have canines? You need to eat all meat, no carbs. We've been doing it the wrong way. Flour products. And then it was the Mediterranean diet. We need nuts and oils and salads and, good fats, avocados, and there's trans fats that we can't clear in McDonald's French fries. And then it's the caveman diet. And then, the reality of it is they all work for a while, but you can't stay on them unless you, kind of mix it up a little bit. And that's what I would say to you. I mean, this, to me, you have to drink lots of water. You have to keep your stomach full. You have to plan your meals. You have to not wait till you're absolutely starving. If you can bring, salmon in the house. I know the kids are going to complain, whatever sometimes, but they'll eat it. If you can fill yourself up with a little bit of salad and find something that you like in it, like, who knows, black olives, maybe romaine, maybe mixed chopped greens, something like that. Almonds are awesome source of protein during the day that don't have like sea salt all over them. But we're all just trying to do a little better. But that's what I have to say about diets. I've looked at them all. There's no difference. Just try to lose 10% of your weight. Next. Okay, this just basically shows you that exercise and walking works. Your amount of physical activity will lower your all-cause mortality. Walking is just fine. Adding something with walking like stretching or, light toning or yoga or whatever you like. Some people say, oh, well, Jim Fixx was a great marathon runner. He died running. The studies show that, you burn more calories, you walk 10,000 steps a day, it helps. Next slide. I'm going to make this under 30 minutes. Everything's worse with diabetes, and diabetes, generally speaking, is going to be from getting too fat. And I'm too fat, and so it starts out, oh, my blood sugar is 110 on my fasting blood work, and then your hemoglobin A1C goes up. Everything's worse with diabetes. Now, if you have type 1 diabetes, that's a genetic disorder, but sooner or later, your pancreas can't make enough insulin to overcome the amount of weight that you see if you become like Chris Farley. It's just everything's worse with diabetes, and that's what the lines show. Next slide. So this is the next, this would be my 6th point, my last point, really. Everything is going to be tied to your watch sooner or later. It will be. There are people, Eric Topol was the, chief medicine at Mayo Clinic or Cleveland Clinic, I think, actually Cleveland Clinic, and he wrote like the textbook on when we used to look at textbooks as opposed to up to date or whatever. We know we can tell your heart rate from the phone. We can tell your sleeping patterns from the phone. We can tell your blood pressure from the phone. We almost can tell your blood sugar from the phone. We can tell how long you sleep. We can tell breathing. We can tell if you have sleep apnea. We can, next slide. So these will continue to improve, mainly to give you more data. But I used to say, like, if you don't believe in medicine, like I'd have patients come in all the time and say, Doc, I'm just not a medicine taker. I go, well, when you take your insurance physical and your blood pressure is 210/110, which it is here, they're going to charge you, they're going to either deny you or make you pay $300 a month because more, because they know your chances of a stroke or heart attack. I mean, they've got the statistics. They're not into saving your lives. They're into making money. We're into trying to save your life. I'm telling you, blood pressure, cholesterol, diabetes, blood sugar, you know, the weight around your belly, exercise, steps a day, but matter. Wearable technology will continue to improve, but it's going to be like everything else. What do you like? What do you want to get out of it? And when will it be prime time? And then again, when are they going to penalize you for it sooner or later if it becomes accessible to everybody? I don't know, but I know that these smartphones will be able to, we can already, communicate with our doctors. We learned that in COVID big time, that, a lot of actual good could take place over the computer. It doesn't mean it's going to absolutely replace the doctor's visit, but I'll tell you this, it probably should if all you need is a refill. So next slide. That was just basically on hormone replacement therapy that I put there. For women, I worry about stroke. I worry about blood clots. I worry about breast cancer. Like I said, my sister has breast cancer. I wouldn't put her on Premarin. She's on basically breast cancer nowadays, as you guys may know, it's all receptor driven. And if your cancer responds to estrogen, you're on an estrogen blocker. And it definitely helps with, with osteoporosis, but, I'd be careful about it. And I would have, a lot of it depends on your, the perimenopausal symptoms. I mean, that you have, but if you don't have breast cancer in your family and you want to do aggressive screening and it really helps you and it helps your bone density measurements, then, it's okay. But it's a personal decision. Next, and I think that's the end. So what do you think as a rough draft?
That's great.
That was good.
Yeah.
Good.
Okay.
Thank you for sharing all that. That was a lot of useful information. We appreciate that.
Well, you got it. And, honestly, it's always the 6 to 10 people that actually will sit there and actually be open to, just like me with your organization. I mean, you have something to say, something to do. You're making a difference with education and mentorship. Once one of the 3 companies, figures out the right vaccine and whatever, whenever the finish line is crossed, we can go back to social interaction again. I'd love to help in any way.
Yeah. Well, that hopefully will happen soon, because I know all of us are getting tired of trying to live this life. That's for sure.
Okay.
Well, we do want to thank you so much, Dr. French, for doing this for us, and we have it recorded, and we will try and share that with you as well.